All right, today we're going to talk about nursing care of the child with an alteration in tissue integrity or an integumentary disorder. We're going to talk about skin. Now, up in the media section in this module, there is a PowerPoint that has some pictures of some rashes in it. You can take a look at those. We're going to go through the PowerPoint here, and then we're going to hit the chapter like we usually do. Some differences in children and adults related to the skin. The infant's and the toddler's skin is very thin, and absorption of anything that you put on it takes place at a much higher level than it does in an adult. Therefore, if you put a medication on it like a steroid cream, they're going to systemically absorb a lot more of that steroid than an adult. So remember that. It's very thin. It absorbs things a lot quicker. Some causes of any kind of skin disorders in kids and exposure to infectious microorganisms, and lots of infectious things with the skin. There's fungal infections, there's bacterial infections, there's even viral exanthems, which are manifestations of a systemic viral disease. Hypersensitivity reactions, aka allergic reactions, hormonal influences like acne, genetic predisposition like psoriasis can be genetic. Injuries, of course, abrasions, lacerations. Lacerations, they don't really talk about lacerations in the chapter, but I'll mention a little bit of stuff about lacerations. Abrasions, those types of situations, they're all pretty easy to take care of. Darker skinned children and infants tend to develop some hypertrophic scarring, keloids. There's also Mongolian spots that you see in darker skinned kids. They almost look like bruises, so a lot of times we get child abuse suspicions when they're really Mongolian spots. So some lab tests that you might see with skin disorders. CBC if you're looking at an infectious process. ESR to talk about inflammation. IgE is an allergic or an atopic marker. So if you are suspecting an allergic reaction to something, IgE might be something that they look at. Culture, if you have wound drainage, you may do a culture and sensitivity. KOH prep, looking for fungal infections. Allergy testing, looking for hypersensitivity reactions. And a Woods lamp. Let me think on that one. All right, some lab tests that you might see for burns, and it does have a nice burn section in the text that we'll go over. Fortunately, well, we don't see too many pediatric burns, but they are a special case. With a burn, you want to look at electrolytes, CBC, looking for infection, electrolytes because they lose so many fluids with burn situations. Culture of the wound drainage if you suspect an infection. Nutrition status to promote healing. Definitely pulmonary status. Scanning for inhalation injury. If you have flash burns to the face or singed nose hairs, then you always want to investigate an airway injury. An EKG if you are dealing with like a shock situation, if they got shocked, if it's an electrical burn, etc. All right, some terms. So whenever you see a rash, you're going to need to be able to describe it. So you need to know what each of these really look like. A macule is just like a flat red area. A papule is a skin-colored, flesh-colored lesion. Annular means round. Pruritus means itchy. Vesicle is a blistery type thing from chickenpox. Poison ivy, those are both vesicular lesions. Pustule is just what it sounds like. It's a pus-filled lesion. Scaling or plaques, those tend to go along with psoriasis, maybe ringworm. And hypo or hyperpigmented, either they're dark or they have no pigment. And erythematous means red and swollen. Some types of infections that you're going to see. Bacterial infections it talks about, impetigo, folliculitis, cellulitis, MRSA. These are all pretty much caused by staph. Sometimes strep causes those too. Both of those bacteria you have on your normal flora. So that's kind of an opportunistic infectious process. Fungal infections, tinea. There's lots of Tineas. We'll talk about each one of those. Yeast is also a fungal infection. And then viral infections like viral exanthems, rashes from viral illnesses, or herpes simplex is a viral infection as well. All right, here's our Tineas. And I think there's some really good pictures in the book too about what the tinea is. Tinea pedis is a fungal infection on the feet, usually between the toes. A lot of times football players and people that take showers in public places get that between their toes. It's very itchy. Not that I know, but it's very itchy. Tinea corporis, fungal infection on the arms or legs. That's your typical ringworm. So arms, legs, face, etc. That tends to kind of be associated with cats. So if you have a patient with a lot of ringworm, then you might see if they have a cat. I think it has something to do with if they're an outdoor cat and they're in the dirt clawing and they have their claws that fungus in their claws and they come in, scratch the kid, get a ringworm. Tinea versicolor is a fungal infection on the trunk and extremities, and it's the hypopigmented phenomena that you'll see. Tinea capitis is ringworm in your scalp, and that requires oral antifungals for a long time. So that's some pretty intense treatment. And then Tinea cruris is good old jock itch. It is caused by fungal infections, sweaty situations. There you go. I'm going to leave it at that. All right. Nurse is assessing a child who presents with patches of scaling on the scalp and central hair loss. What fungal rash does this signify? And that would be Tinea capitis. Again, it has to be treated with a oral antifungal called griseofulvin, and it's got some very specific dosing instructions we'll talk about in just a second. All right, MRSA. Now, I think we talked a little bit about this in the infectious disease podcast. MRSA is becoming more and more prevalent. Probably a lot of healthcare workers harbor this in their nose. It comes from, and CA stands for community acquired. Used to be just kind of a hospital acquired disease or bacteria, but now it's out in the community. So it's out there. Some inflammatory conditions that you might see, hypersensitivity reactions, aka allergic reactions, contact dermatitis, diaper dermatitis, fancy names for diaper rash, and eczema. No, I'm sorry, not eczema, like poison ivy, allergic reactions to nickel, those are contact dermatitis. Atopic dermatitis is a fancy name for eczema. Chronic inflammatory disorders like seborrhea, cradle cap, that's cradle cap, in infant psoriasis, those are chronic inflammatory disorders. Contact dermatitis is a response to something that your skin comes in contact with. So if you're assessing a child and they just have a rash over their arms and legs, they may have been exposed to something that didn't hit where their clothes were. So that probably would be a contact dermatitis. Versus if you have a all over body rash, that may be a hypersensitivity to a food. So assess your location of your rash and then think through the process. Okay, is there a possibility that they were exposed only on these areas? So a good thorough assessment under the clothes with rashes. Okay, exposure to poison ivy, poison oak, those are all contact dermatitis. And then what can happen from that? Well, if anybody has ever had poison ivy, and I'm itching right now, they know that it's very, very itchy. So sometimes a secondary bacterial infection might happen from that. Hyperpigmentation or lichenification, Too many eyes in there. That can happen if you constantly itch, 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 scratch, scratch, scratch. So just know that that may be a complication. It also may be a complication of eczema too. All right, acne. Acne is a bacterial infection, basically. You have 3 levels or 3 classifications. You have mild acne, moderate acne, and severe acne. You need to know what each one of them look like and how to classify them. Question is the following statement true or false? The nurse is assessing a child for acne vulgaris and notes comedones plus papules localized on the face. This is classified as mild acne. True or false? False. This is moderate acne. All right, classification for burns. Burns used to be first, second, third, fourth degree. Or first, second, third degree, sorry. Now we call them superficial, partial thickness, deep partial thickness, and full thickness. That's how we describe burns. Superficial is like a sunburn, only the epidermis is involved. Partial thickness involves the epidermis and portions of the dermis. Deep partial is a little deeper. Full thickness goes all the way through. When we get a pediatric burn, most of the time those are going to go to burn centers. Now around here, Parkland is a burn center. I am not sure if there are any other burn centers. I know that we just send everything to Parkland because they are nationally known for their burn care. Partial thickness burns greater than 10% of the body, babies go to Parkland. Burns that involve the face, babies go to Parkland. Joints, because you can think about the scar tissue, how that's going to make those joints immobile, so they also get transferred out. Electrical burns, chemical burns, and any kind of inhalation injury, we try to transfer those out as well. Here's some more criteria. If you have a burn and a traumatic injury, you might go to a trauma center because they can take care of both situations, especially if it's Parkland. So if you have a burn, traumatic injury, car accident, those will probably be transferred out. Pre-existing conditions. Now this is a little bit tenuous because the pediatric specialists are at the pediatric facility, and if it's not a pediatric burn center, say it's Parkland, then there may be a little bit of a care coordination dilemma. Fortunately, Children's is right there by Parkland, so I'm sure that they share doctors if there is a chronic kid that gets burned. All right, some hypersensitivity reactions. Most of the time it's an allergen, like a chemical allergen or a bee sting. Those cause hypersensitivity. If it is like a food reaction, then you're going to see pretty much full body involvement. If it's more just a contact from a bee sting, you're going to see a local reaction. Now, erythema multiforme can be, it's kind of a weirdo. It can be allergic reaction to a virus. And I know that sounds strange, but the book explains it a little bit better. So we'll hit that when we see it. It can also be like a drug reaction. Stevens-Johnson syndrome is a form of erythema multiforme. There's mild forms, very mild forms, and then there's very serious forms like Stevens-Johnson, and you can actually, it's got like a 10% mortality rate, so it's pretty serious. All right, so what are we going to do to treat these ailments? You might see some wet dressings, occlusive dressings. Most of the time it's something topical, either a topical antibiotic cream or a moisturizer. Most of the time that's how we're going to treat these illnesses. Now if it is kind of a resistant bacteria or a long-standing cellulitis, they might get an oral antibiotic to go with that. If it's serious enough, if it involves like the periorbital cellulitis, then they may actually get some IV antibiotics. Oh, speaking of which, here we go. Antibiotics, either topical or systemic, corticosteroids for hypersensitivity reactions, steroid creams, antifungals for any of the tinea, unless it is Tinea capitis, and then that's treated with a PO antifungal. Topical immune modulators, those are eczema treatments. Antihistamine, Benadryl cream. Accutane, isotretinoin, which is Accutane, may be used for severe acne. It has some pretty heavy side effects, so they try not to use Accutane if they can get away with it. Coal tar preparations for psoriasis, for atopic dermatitis, silver sulfadine or sylvadine for burns. Another one that's not listed on here is like dandruff shampoo for seborrhea. That's used pretty commonly too. All right, the nurse is caring for a child with severe atopic dermatitis. Which of the following medications do you think we're going to give them? Answer is B. Topical immune modulators. That's what we give, or what we put on for eczema. All right, urticaria. Now, urticaria is kind of a broad category for some sort of allergic type reaction or some sort of hypersensitivity reaction. It can be foods, it can be meds. If you have a penicillin allergy, sometimes you see an urticaria with that. Hives is another name for it. With a reaction with an urticaria, you always want to make sure you assess airway, because if it is an allergic reaction, you know, the airway can be involved. So, and also if you have a reaction one time, the next reaction may be even worse. So make sure that parents know to assess respiratory status if their child developed like a rash from penicillin or whatever. Oh, there's our causes of urticaria. Allergic reaction to food. Peanuts are a big offender. What else? Wheat's a big offender. Strawberries sometimes. Tomatoes. Drugs. Penicillin is always a big offender. Animal stings. Animal bites. Stress. You can have stress urticaria. You can just break out in hives for no reason at all. Well, for psychological reasons like stress. All right, here's some more burn information. These PowerPoint slides are a tad bit out of order. Sorry about that. What do we want to do for our children that have burns? Well, you want to make sure that they're oxygenated and ventilated. Most of the time, especially if they have a facial burn or if they're suspected to have an inhalation burn, they will be prophylactically intubated just to get ahead of that swelling that might occur. Fluid volume, they lose a ton of fluid. There is a special, it's actually called the Parkland formula for replacing fluid volume in burn patients. You want to prevent hypothermia because they have no way to regulate their temperature if the burns are severe enough. Cleansing the burn. Okay, so whirlpool, debriding, very, 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 very painful. So make sure that you take care of pain control before you try to go clean burns. It's kind of inhumane not to medicate for pain before you do burn cleaning or burn wound debridement. Prevent infection because they have just one big open sore, so you want to, they're definitely in isolation. Manage your pain, treat your infected burns with antibiotics, and then once they start to heal, you're going to have to do there will have to be some serious rehab done, especially if it involved a joint. Mobility can be a big issue. Diaper rash. How do you prevent diaper rash? Well, here's a bunch of different ways. Make sure you change the diaper pretty frequently. If it's a dirty diaper, it needs to come off ASAP. Don't let them run around in rubber pants because that kind of holds all the moisture in. You can use baby wipes. Don't use any kind of harsh soaps. Soap and water is plenty. No smelly, fragrancy foo-foo wipes. And then you can apply a moisture barrier. The white stuff is best. It's a zinc base. And it's like A&D white or Boudreaux's butt paste. Those are all good white, good moisture barriers. All right, so how do we avoid getting bit by an animal? Well, don't poke the dog. Don't poke the bear. Good teaching points here to share with parents. Keep ferrets away from the face. Well, I will keep my ferret away from my face. All right, so now let's go look at the chapter. Chapter's a little bit more thorough in explaining a lot of these things. One thing that I do want you to remember about difference between skin in children and adults, children's skin much thinner, much more absorbative, if that's a word. There's a good picture of a keloid. Again, that's just a scar, what's it called? Hypertrophic scarring. So it's just a scar on steroids. Okay, here's some, let's talk about sunscreen real quick. We didn't touch on that. I looked up some guidelines for sunscreen as far as the SPF, and all of the references that I found had 15 or higher. I would have expected it to be much more. That's why I wanted to look it up, because that's what the text says, 15 or higher, but I would have expected it to be much higher in kids, but that's what they recommend, 15 or higher. Put it on 30 minutes before you go out and then reapply it every 2 hours. If they're in the water, they need to have it reapplied every hour. All right, and here are the medications again. Talks about indications for each and nursing implications. A good chart to look over. Look down at antifungals, and it talks about griseofulvin. All right, so griseofulvin is what they give for Tinea capitis, and it is an oral antifungal. Takes 4 weeks for complete treatment. You have to give it with the fattiest meal of the day. So the fat aids in the absorption of the medication. So fatty food, griseofulvin for 4 weeks for Tinea capitis. Benzoyl peroxide is a topical medication that they use for acne. That's what they try to use before they use Accutane. Sorry. Okay, antihistamine, Benadryl will help with itching. Systemic steroids, sometimes like with poison ivy, you'll see them prescribed like a dose pack, a steroid dose pack, to reduce the inflammatory process. All right, assessment when you are assessing a rash. Okay, so let me make a general broad statement about rashes. Rashes are hard to diagnose. Unless they are very characteristic of like a impetigo or something like that. Rashes can be related to anything, so a good health history is super important. You want to know if they've had any new foods, if they've had any new soaps, any new lotions, any new laundry soap. I mean, you want to be a private investigator. You got to ask the right questions. If they've been outside, if they've been playing, if anybody else at home has the same rash. So lots of questions. When you're doing a physical examination, you want to use those terms that we talked about to describe what you see. If it's a linear line of vesicles, you can think about poison ivy. Make sure you describe the shape. Are they round? Are they oval? Do they have a central clearing spot? Do they have like a bullseye, like a target lesion? You need to describe it very thoroughly. This just talks about some tests, and we've talked about all of those. Okay, so infectious disorders, bacterial infections. One of the most common ones you'll see is impetigo. Remember I said bacterial infections for the most part are caused by staph or strep. Impetigo is caused by staph. Kids harbor, this is going to be gross, kids harbor staph in their nose. They are nose pickers. So if they disrupt that bacteria, touch their face, they can self-inoculate, cause impetigo. This is a fairly bad case of impetigo. Whenever you see the words honey-colored crust, think impetigo. It's usually on the face and the nose, but you can self-inoculate anywhere. I've seen it on the legs before, and it's basically a staph infection. Now, for a mild case, they try to treat with topical antibiotics, oh gosh, the name has escaped me. Not Neosporin, but the stronger one. Oh, I can't believe I can't think of it. I'll think of it here in a second. Topical antibiotic cream. Sometimes they have to do like a PO antibiotic as well. Bacterban, there we go. Sometimes they try to use topical Bacterban. Folliculitis is just what it sounds like. It is a staph infection that gets in the follicles. Now, hot tubs are infamous for causing folliculitis. So, again, a question you might ask, have you been in a hot tub? Wide systemic rash everywhere except for the bathing suit area? Maybe folliculitis. Cellulitis is a progression of that. It's a little bit more involved. It goes a little bit deeper. Sometimes it's preceded by trauma, whether it be a cut or a scratch or a laceration. So cellulitis is something you'll see. And most of the time for cellulitis, if it's a true cellulitis, they'll get an oral antibiotic to go with that. Staphylococcal scalde syndrome, a little bit more advanced than cellulitis. Okay, so those are your levels right there. MRSA, like we talked about, causes a lot of bacterial skin infections. Here's a cellulitis, and this borders on periorbital cellulitis. That may be an admission with some IV antibiotics. And here's staph scalded skin syndrome, SSSS. It's a sad, sad baby. All right, so what are you going to assess? Again, good history taking, very important. You assess for fever, you inspect the skin everywhere, you document what you see, describe it as best you can. Here are the bacterial infections that we talked about and how you treat them, what they look like, honey-colored crust. Remember that. All right, so fungal infections. Tinea, lots of Tineas. And we talked about each one of these. Here's what you're going to see with each one of the Tineas, and here's how you're going to treat it. Now, it does have some pictures. Oh, we didn't talk about diaper rash with fungal infection. You treat that with topical nystatin. That's a yeast infection. So topical nystatin, there's a really good picture in here that shows the satellite lesions, and I'll show you how to kind of differentiate that between a diaper dermatitis and a yeast infection. All right, so that's a ringworm. That's Tinea corporis. This is Tinea capitis, and usually you have some hair loss. This is Tinea versicolor, hyperpigmented. This is Tinea pedis. Fortunately, it does not have a picture of Tinea cruris, but that looks very itchy on the feet. This is a yeast infection with the satellite lesions. All right, and this is a diaper dermatitis. This is a serious diaper dermatitis. Can you see the difference? All right, this is caused by just a reaction that we stayed in the diaper too long. It also may be caused by if a baby has diarrhea, like from antibiotics. There may be some involvement or maybe some cause there as well. Diarrhea is very acidic and it can kind of excoriate the skin. All right, prevention of diaper dermatitis. This is good teaching points to use. These are good teaching points to use with your parents. Atopic dermatitis or eczema, one of the most common things that you'll see. That is a true story. Now, atopic, remember we talked about allergic conjunctivitis, asthma. It goes along with the atopic dermatitis. So eczema, asthma, allergic conjunctivitis, seasonal allergies, that kind of all goes together in that allergic cascade. Here's some things that you're going to see with a child with asthma. It's very itchy, so you might have some sleep disturbances. They're going to be irritable because they're not getting any sleep. This is a pretty good case of eczema on the face. You have to be really careful with steroid creams on the face because baby skins are very absorptive. All right, you want to basically hydrate your eczema. So Eucerin, Aquaphor, those are all good, thick, nice emollient moisturizers. Vaseline, it's cheap and it's good. So moisturize that eczema. Contact dermatitis, again, is when they come into contact with something, nickel, poison ivy, some sort of chemical reaction to a cleaner, And that's poison ivy. See how linear that is? And if you can look really close, they're vesicular lesions. Here's how we prevent contact dermatitis. And one of the things you need to focus on with contact dermatitis, especially if it's very itchy, pruritic, I guess I should be using the real word, infection control, because you can get a staph infection pretty darn quick if you continue to scratch and itch. Erythema multiforme. So here's a picture of erythema multiforme. Again, it's an allergic reaction to a virus or a med. I don't want to say it's an allergic reaction to a med, but it's a hypersensitivity reaction to a med. Very similar. Mortality rate of about 10% with Stevens-Johnson syndrome. So it can advance from this to a Stevens-Johnson syndrome. Urticaria. Now, can you see how these can be confused? Look at erythema multiforme and look at urticaria. What's going to make your difference here is your history taking. Okay. Seborrhea or cradle cap. That's a pretty severe case of cradle cap. Here's some nursing management tips for how you take care of cradle cap. Don't pick off the crust. Tell parents not to pick off the crust. Dandruff shampoo is what you want to use. Psoriasis. This is a case of psoriasis, and psoriasis is a chronic disorder. It's kind of like an autoimmune thing. There are treatments for that. There's lots of, especially if the lesions are visible, there's lots of psychosocial issues with psoriasis. It can look really really impressive, really kind of scary, especially with kids. So lots of psychosocial issues involved with that. It can be managed. You can get it into remission, but it's a disease that you really have to concentrate and be very compliant on your treatment. All right, acne. Now remember I said there's those 3 levels of acne. You need to know those. How do we manage that? We focus on skin care. Usually use a benzoyl peroxide preparation first. Then they can progress on if they need to use an Accutane or even like a doxycycline, oral antibiotic. Sometimes that helps as well. Teach them not to pop their pimples. That's what they want to do. So you're going to have some serious scarring if you do that. Here's your classifications again. This is some information about fetal exposure to Accutane. Again, they try not to use it if they can get away with it, but if it's the only thing that controls the acne, then really need to monitor it. All right, some injuries. Kids can get pressure ulcers, especially if they're immobile. Femur fractures are immobilized for 6 weeks, so they can get skin breakdown. Under cast, make sure that you have your parents evaluate that for any kind of pressure ulcers or rubs on the skin. Minor injuries, lacerations, falls, and abrasions. Just keep the wound clean and dry, especially if it's sutured. You're going to get some really good wound care instructions when you have a laceration. Make sure that the parents know when to have the stitches taken out, and they don't leave them in too long, etc. Okay, and then here's the information on burns. This is when we're going to transfer them out to a burn unit. We talked about that. One chart I want to show you is, well, it may have been pretty far down here, this one. Okay, this talks about, remember I said we don't use body surface area for medication administration. We don't usually use it for med administration. However, with burns, they do a BSA, body surface area. So this is a chart that kind of gives you the total body surface area affected by age breakdown. So if you have a birth to 1 year and you have the head affected, you have 19% of the body affected. All right, read through this section on burns. Lots of good information here. very specific to burns. Pain management is really important. Pain management may even be sedation when they have to do wound care. Here's some information about burn care and skin grafts. Here is an example of a healed skin graft. Now, I can't really tell how far that goes up. It looks like it goes down not to the elbow, not to the AC, the flex there. So hopefully this didn't require too much rehab. But if it did, extend over into the shoulder or down through that first, through your elbow joint, then rehab, physical therapy would be involved. Carbon monoxide poisoning with burns doesn't have anything to do with the skin, but some good teaching on carbon monoxide poisoning could happen here. Here's some burn prevention. These are great things to teach your parents. And then burn care at home. Parents do take care of burn care or take care of burns at home. Usually it's a Sylvadene, change the dressing type regimen. So good teaching there. Make sure they wash their hands and know when to come back. Sunburn, we talked about SPF at minimum 15. Reapply every hour if they're in the water, every 2 hours if they're not in the water, 30 minutes before they go out into the sun, put it on. Frostbite. Not something that we see a lot around here, but the treatment for frostbite is to warm up the offended area. That can be very painful. So know that pain management is important in frostbite. Human and animal bites. Here's some good teaching points again on how not to get bit by a dog, and keep your ferrets away from the kid's face. Bee stings, spider bites, we see a ton of that. Insect stings, mosquito bites. One of the main complications of that is infection. If kids scratch, or if they're pickers, then those little ones can get infected. Most of the time a Neosporin topical is enough to take care of that. However, sometimes we have to move on to the Bactriban, the higher potency topical antibiotic. Spider bites, parents panic at spider bites. There are really only two spiders that we get excited about, a black widow and a brown recluse. Black widow has some neurotoxin release, so it can have some neuro symptoms. A brown recluse, you actually did take care of a patient, an adult patient with a brown recluse spider bite on her chest, and it had a huge big black necrotic area in the center, debriding, wound care, infection, IV antibiotics, etc. That's what we had to do with her. So those two are pretty serious. Just a little. And a lot of times you can't even tell if it's an insect bite or a spider bite. So just a little bite most of the time is very benign. So encourage parents that it may be a spider bite. We may never know what bit your child, but these are the things to watch for, and this is how we're going to treat it. All pretty much treated the same way. Okay, so here's your care plan. Talks about treating skin issues, prevention of skin issues like secondary infection, appropriate body image. If we have like a psoriasis, sometimes that can affect body image, and then nutrition and fluid balance with burns to promote healing.